Good morning, everyone. So this is session 4 of our RaCEEs course. We're now halfway through the course. After this session, we'll take a break until the 13th of January, if I'm not mistaken. And today we are going to talk about outcomes. So you remember last time we covered cost. Now we're going to move into outcomes. And I'm co-running this session together with Misael. Misael, would you like to introduce yourself?
Yes, hello. My name is Misael. I'm based at Lancaster University, or part also from the MIDAS team. So I'm a health economist.
Perfect. Thanks, Misael. As usual, I need to remind you that this session is being recorded and it will be made available on the Arc Nord West Coast YouTube channel. If you have any questions about recording, please let us know. Okay, let's make a start. As usual, I'm going to ask you if you have any quick questions about the homework post session 3. I know a lot of you have done the homework and we will try to give you feedback as soon as we can. But if you have any quick questions you want to cover now, just feel free to unmute yourself and ask. If you find anything difficult or any problems, just let us know. Okay. Now, session 4. So we're going to cover outcomes today, and in terms of the structure of the commentary, we are still in the method section, and then with next session we're going to move into the results section. But what I want to say before we actually talk about outcomes is that we got a date for the workshop now, and the workshop will be on Tuesday, 11th of March at UCLan, University of Central Lancashire in Preston, in the Engineering and Innovation Centre. I'm going to send you a placeholder invite after today's session, so you can have the invite in your calendar and save the date. I'm going to give you details about the room as well. It's going to be an all-day workshop, so we are aiming to start, I think, at 9:30 in the morning, probably until 4:30. We still need to decide the timing precisely. But yeah, I'll send you all the details in the calendar invite, and it would be really great if you can let us know as soon as you can if you can attend or not. And yeah, we just need to make some arrangements regarding logistics and catering, as you probably can guess. So it'd be really great if you can let us know as soon as you can if you can make it or not. So as I was saying before, we are still in the method section of our commentary. We are covering outcomes today, and then next session we are going to cover the results. And the aim of today's session is to identify and describe the characteristics of the outcome data and the type of discounting used in economic evaluation. I'm going to talk in a minute about the cost effectiveness plane, and then Misael will provide very good examples about cost effectiveness decision, which will allow us to think about cost and outcome together and how the two interact. And then we're going to cover clinical effectiveness outcomes, composite outcomes, and we also cover discounting towards the end of the session. Okay, typical diagram of the economic evaluation, where you've got two alternatives. Last time we talked about cost, and now we are going to move towards the consequences, the outcome side of things. And I want to start this session by talking about the cost effectiveness plane. I will say this is probably one of the most important and fundamental diagram you will see in health economics in general. Probably, if you open any textbook on health economic evaluations, you probably see this diagram there at some point. And it basically condenses in just one slide here what you need to know about the interaction about costs and outcomes, which are useful to understand in an economic evaluation. So let's try to dissect this diagram and try to talk about each component one by one. So first of all, is a plane. So you will have also two axes, a vertical and an horizontal axis. On the horizontal axis, we got the effectiveness of the treatment. on the vertical axis, we are instead considering the costs of a treatment. So costs and effectiveness are depicted in these two axes here. So on the vertical axis, if we are at the top side of the vertical axis, we got the situation where the new treatment is more costly than the existing treatment, for example, usual care. If instead we are towards the bottom of the vertical axis, we got a situation where the new treatment is less costly. Sorry, man. Yeah, the date is the 11th of March, Tuesday, 11th of March in UCLan. I will send all the details later on.
Thank you. Sorry to disturb, Valerio. Sorry, thanks.
So, oh, thank you, Alison. I've seen your message as well. Yeah, okay. So even if you can manage to attend for part of the day, that would be really great for us. Yeah, absolutely. Okay, so in terms of the vertical axis, we got the cost. So new treatment might be more or less costly than the existing treatment or usual care. Let's move to the horizontal axis now, where we got the situation where the new treatment might be more or less effective than existing treatment. So if we are on the right-hand side of this plane, the new treatment is more effective. If you are towards the left-hand side of the plane, the new treatment is less effective. So we got two axes. So that means we are dividing the plane in 4 quadrants, and we are going to analyze these 4 quadrants one by one now. So we'll start with the northwest quadrant, which is the quadrant towards the top left-hand side of the plane. And if you see in this quadrant, we got the scenario where the new treatment is more costly, but is also less effective. So that means it's going to require more money to implement the new treatment, and it's not going to bring us the same amount of health gains that existing treatment is bringing about. So the existing treatment in this scenario will dominate the new treatment. Vice versa, if we move to the southeast quadrant, we have the opposite situation where the new treatment is more effective and less costly than the existing treatment. So the new treatment will dominate, will be superior than the existing treatment in this case. Now you can guess, we also got 2 quadrants where the situation is a bit more tricky to understand and decipher in a way. So southwest quadrant, new treatment is less effective and less costly. So we save money, but at the same time, we don't gain the same health gains that we will earn with the existing treatment. So what do we do here? It's a question whether we are happy to save some money in order to maybe forego some health outcomes, or maybe we're not so happy to do so. It's kind of an ethical decision here as well. The most common situation, I will say, is this one on the northeast quadrant, where the new treatment is more costly, but it's also more effective. That's because usually when you implement something new, you will have some higher cost that you will need to consider: training, equipment, anything that you will need to buy or invest in order to make the new treatment applicable and implementable across your healthcare system. So the new treatment might be more costly, but there's also promise that the new treatment is more effective than existing treatment. So the northeast quadrant is, again, another quadrant where we got this trade-off between cost and effectiveness. And we need to decide as decision makers, let's say, that at what point we are happy to accept this higher amount of cost in order to gain more health in a way. So there are more health benefits with the new treatment while we are spending more. Now there will be an amount of cost where we are happy to incur this cost, but beyond a certain threshold, we might not be so happy to incur this cost. So any health outcomes or any health benefits beyond this cost threshold. We are not happy anymore to sustain this cost for whatever reason, because we don't have the resources in our budget, for example. So it's not a clear-cut decision here. We need to have a threshold in mind in order to understand, okay, I'm happy to incur this cost, I'm not so happy anymore to incur this cost. So beyond this threshold, there is a decision we need to make around the cost effectiveness or the lack of cost effectiveness of a new treatment. We will talk about this plane a bit more in detail in session 5, where when we will talk about the results of economic evaluation. Now, before I move to, I'll leave the stage to Misael. Do you have any questions on the plane? Okay, I'll stop sharing, Misael, and then you can share your slides.
Okay.
Thank you.
Can you see my screen now or not yet?
Yes, we can. Yeah, thank you, sir.
Okay. So this is one example of cost effectiveness decisions. So let's suppose that we have 2 drugs, new drugs in the market. And drug A can extend life by 1 year, and it costs £100. And we have also drug B that also can extend life by 1 year and also cost £300. So here, which one to choose? So without further information, if we are forced to choose, we will choose drug A. This is because drug A can produce the same extra years of life using fewer resources than drug B. So even without further information, even if we have unlimited resources, there is no reason to choose drug B, because we will waste £200 that can be used elsewhere in the system. But now let's assume that drug B can extend life by 2 years. So, it can be changed from presenter mode. Let me just check if it can be done. Okay, now better. Perfect. So let's see now that we have drug B. Now drug B can extend 2 years of life. So which one to choose? In this case, more realistically, we need a concept which is called net benefit. The net benefit is the number of additional years compared to the overall NHS. So let's say that there is a study of the overall NHS, how much it can produce, and we have information that the NHS can produce 1 additional year per £50. So this is called the opportunity cost at which the NHS can produce one additional year of life, and is currently producing 1 additional year per £50. So the net benefit will be estimated as follows. So at price of £100, drug A can extend life by 1 year. But with the same £100, the NHS could produce 2 years of life. It's 100 between 50. So, which means the NHS will lose 2 years of life elsewhere in the system in order to finance drug A, which will only add 1 year of life. Then the net benefit will be negative, minus 1 year of life. And what will be the next benefit of drug B? Okay, drug B is costing £300. So at that cost, drug B can produce 2 years of life, whereas the NHS will produce 6 years of life with the same amount, £300 between 50. which means that the NHS will lose 6 years of life elsewhere in the system in order to finance drug B. So, and the net benefit will be 4 years, minus 4 years of life. So which one to choose? So none of them. None of them are cost effective because in order to, they are gaining less years than the NHS is losing in the system in order to finance them. So none of them are cost effective. So the decision will be don't finance any of them. Okay, let's change a bit the example. Let's tweak a bit the example. So let's say now that the NHS can produce this additional year with £100. So as you can see, drug A and the NHS now is producing one additional year with the same cost. So it's not easy, it's not difficult to see that the net benefit will be 0. Okay, because the NHS will lose one year elsewhere, and the drug A will gain 1 year. So the net benefit will be 0. But regarding drug B, this still is not cost effective because it will reduce 1 year of life. Okay, the net benefit will be negative. So then we can show that if the opportunity cost, so which is the cost that the NHS is producing what an initial year of life, is slightly greater than 100, let's say 101, then drug A will become cost effective because it will produce more years of life than the system is losing elsewhere. Okay. Now, let's change a bit example, and it says that now the NHS is producing one additional year of life at £200. Doing the same maths, we will show that the net benefit will be half a year for each drug. So this is greater than 0, okay? Which means both drugs are cost effective regarding to the NHS. However, if we want to choose between them, both of them are producing the same amount. So which means we can choose either A or B or both. At this threshold, £200, both of them are indifferent. However, we can show also, just with a little tweak of the example, that to values higher than 200, 201, drug B will be more cost effective than drug A. Okay, so we'll gain more additional years of life than drug A. Then it follows that our decision between choosing between both drugs will depend on the threshold, will depend on the opportunity cost, which is the cost at which the NHS is producing one additional year of life. So we have this threshold line from 0 to 100, so less than 100, neither drug A or B are cost effective. So, because financing them will require losing more years of life in the whole system. From 100 to 200, drug A is cost effective, which means it will produce more years of life than the NHS overall, and also than drug B, because drug B from 150 will have a positive cost effectiveness value, but they still will be lower than drug A. And then for values higher than 200, drug B will be cost effective and will be higher than drug A. So the decision will change depending on the threshold. Fortunately, we have a threshold. So there are studies that shows that the threshold is around 20,000 pounds to 30,000 pounds per QALY, which is quality adjusted life years. So we have an opportunity cost that the NICE is using to decide which technology or which drug is coming in the system. So I hope this can explain more or less the basic idea how we decide which drug or which technology is cost effective or not. I'm happy to answer your question before handing over to Valerio.
Thank you, Misael. Yeah, let's see if people got questions before we move on.
Okay, it's fine. We can receive questions afterwards.
Yeah, of course.
I will stop sharing. Oh, Alison, yes.
It might be a stupid question, and the doorbell went in the middle of it, so I'm really sorry. I get the generalized maths of it, but when you say your cost effectiveness compared with from somewhere else in the system, that's the bit that throws me. How do you get that somewhere else in the system figure? Is that based on the current treatment for that condition?
It's from the whole system. So the NHS.
Somewhere there's because you change the figures. So is there a sort of set figures that for a QALY?
It's 20,000 pounds per QALY.
Right, sorry, I might have missed that bit because like I say, the postman came. I'm really sorry. Thank you.
Yeah, so there are currently studies that measure that, and also there are discussions around that measure. So that is objectively estimated, so we can rule which one is cost effective according to that threshold.
Okay, thank you.
Any other questions? Okay, thank you. We will discuss more the threshold in the next session as well. So you will see how it's operationalized in an actual paper, and we'll have discussion around the threshold. And it's important to notice that not all countries, not all jurisdictions got a threshold as well. So the UK is a famous case around the world where you got a threshold for an additional QALY. Other countries, not all the countries have got a threshold. So it's not a common approach, let's say. Okay, I'm going to talk about types of outcomes a bit more in detail now.
Sorry, I raised my hand, sorry. Just thinking about the cost a little bit and reflecting on the last assignment that we did.
Oh, yeah.
So the cost we are going to incorporate in this, would it be at the point where the decision is being made, will the cost only be that the cost of that drug itself, using the example that Mr. used, or including the cost of administering the drugs? You know what I mean? Like, because we are comparing now, because I just try to reflect that to the benchmark we are comparing to. We use examples of £100, £200, £300.
Yeah.
And we know we have a 30,000 or 20,000 pound boundary. So what cost are we comparing for the QALY? Is it the entire cost, including the rehabilitation cost, if any, for example, or just the technology or the drug we are?
It will be all the costs beyond the actual drug. So it will be any marginal cost that you will need to think about or consider in order to implement that particular treatment. In your case, in your example, the drug. So you will think about whether you need to train people into administering that drug, any complications maybe, any, like you were mentioning, rehabilitation, if there is any, as a consequences of taking the drug in combination with other treatments, for example. So it will be anything marginal for the healthcare system in order to implement that drug,
Yeah, and also the example is just a basic example to put a number, a basic figure, saying how the cost is related with the threshold and how we can compare between them. But of course, defining the cost is a whole difficult business. So it's not like say how much is the cost of the drug, but it's also the consequences of that treatment, so the application and possible effects. Of course, the threshold also is not like just dividing how many years is produced in the system. It's also a bunch of methods just to estimate what is a threshold. And we can discuss also if it is well done or not, for example.
Any other questions? So look at the chat.
I just wanted to throw a bit more kind of just to reflect on the practicalities of it. I remember during the COVID time, there were a lot of vaccines circulating in the system, and then there were kind of technologies. I can't recall which exact one, but there was one of them that required like heavy freezing before it can be administered and all that. So I remember kind of developing countries had to decide on whether they are ready to invest in that extra cost of having to get it frozen and all those things. So just to add to what Latif was asking, and I think people went for the one that required less like additional cost of keeping it frozen and all that. So yeah.
That's the thing. There are costs which emerge as you use the specific treatment or drug, which you need to consider and then add to your calculations. Absolutely, that's a good point.
And sometimes maintaining the drug is more costly than producing that.
Of course,
yeah,
absolutely.
Yeah,
very good point. Thank you, Ruben. Okay, so this is the table with the different types of economic evaluation, which I think we discussed in session 2, if I remember well. I'm not going to cover all this again. I just want to focus for today on the most common types of economic evaluations, perhaps the cost-consequence analysis and cost-effectiveness analysis, which consider outcomes on by estimating natural units, by taking into account natural units. And we will compare this approach to cost utility analysis, where instead outcomes are estimated by considering healthy years, which is a kind of a composite outcome. Now, let's talk about clinical effectiveness outcomes, which apply to cost effectiveness analysis and cost consequence analysis. Clinical effectiveness outcomes, they measure how good the interventions are, and in a CCA, cost consequence analysis, you will have all these different types of clinical effectiveness outcomes listed in a disaggregated way, all separately. There might be process outcomes as well, considering that there might be some monetary outcomes like cost per patient, cost for the patient, for example. But in a cost consequence analysis, usually up to the decision maker to understand or have an idea about the relative importance of the different outcomes. So if the focus of the decision maker is on health outcome, of course, clinical effectiveness outcome will be very key. If the focus of the decision maker is on satisfaction, for example, then you will have probably other outcomes related to satisfaction that will be more important than other types of outcomes. In a cost effectiveness analysis, instead, we focus on a selection of key clinical outcomes which are usually linked to the primary outcome measure in a study. So rather than considering things all separate, in a cost effectiveness analysis, we bring things a bit together and focus onto the primary outcome measure. And I will show you some examples in a second. The cost effectiveness analysis aims to calculate the cost per additional gain in health. And again, we are now considering this interaction between cost and effectiveness, so cost per additional gain in health here. Ideally, in an economic evaluation in general, in a cost effectiveness analysis specifically, you would like to estimate or try to measure long-term outcomes. So you would like to estimate in the long term how effective the interventions are. For example, cost per life year gained, cost per improvement in quality of life. So whether your life expectancy increases as a consequence of receiving an intervention, whether your quality of life increases, improves as a consequence of receiving an intervention. However, that's not always practically possible to measure long-term outcomes. So sometimes we have to rely on surrogate outcomes, so intermediate outcomes, which are more short-term. Here you got some examples. So for example, if you have a study on hypertension, you might want to look at reduction in blood pressure. If you have a study on weight loss, again, you'll be considering an outcome which is, of course, 1 kilo of weight loss, for example. If you have a cancer study, whether you're able to detect a malignant cancer and so on. So for each specific area, disease area, health area, there will be different primary outcome measures that you will have in mind, and you can build your cost effectiveness analysis around these primary outcome measures. Composite outcomes, they apply to cost utility analysis, and they're traditionally or typically centered around this concept of healthy years, which is a combination of quality of life and life expectancy. So we got quality and quantity of life together. Healthy years is operationalized by calculating or estimating quality adjusted life years, or QALYs, which Misael mentioned just a few minutes ago. I'm sure some of you, or many of you, will have heard of QALYs before. We will discuss QALYs a bit more in detail with Misael in a few minutes. And we are going to talk about as estimated, but it's important to understand for now that QALYs are widely used because they represent a kind of common metric across different health or disease area. So when we calculate a cost per additional QALY in a cost utility analysis, we can use that across different health or disease areas. So a QALY will be able to be applied in cancer, diabetes, hypertension, and so on. While if you think about the clinical effectiveness outcomes we were considering before, reduction in blood pressure will be relevant for hypertension studies, for example, maybe not so relevant for other types of disease areas. If you think about the QALYs, which represent quality and quantity of life, so life expectancy and quality of life, these are concepts which are more or less relevant to a lot of different health or disease areas. Now, there are a lot of criticism around QALYs. Not all health or disease areas will be, let's say, relevant for the application of QALYs. A lot of times QALYs have come under criticism because the concept of measuring quality and quantity of life might not be so relevant for some health or disease area, and we will provide you some examples later on. But in the main is a common metric which can be applied across different areas, and that's one of the reasons why it's so widely used in health economic decisions around cost effectiveness. I'll go back with just 1 second to talk about the cost per additional QALY. So if you think about this terminology, cost per additional QALY is again a cost per additional health gain. So you will remember from the previous slides, we were talking about cost per additional health gain with cost effectiveness analysis. And so if you think about it, cost utility analysis are a subtype of a cost effectiveness analysis. At the end of the day, they're very special subtype, probably I would say the most commonly used type of economic evaluation, at least in the UK. The QALYs, or the estimation of the QALYs, is a very economic way to approach things in a way, because when we estimate QALYs, we rely on preference and utility. So we're not measuring a particular quality of life or quantity of life. We also trying to understand the value that people attach to specific health states. And when we're trying to do this valuation approach, when we're trying to apply a value to specific health states, we are doing something that is in economics at least is very common. Assigning preferences or trying to calculate utilities is something that is very important, not only in health economics, but in a lot of different economic disciplines. And now I think with Misael, before we move to Misael example, we are going to give you an example of how to extract and write up the info on the outcomes from a paper. So this is an article which we've been using during the course on advanced Parkinson's disease. We utilized this article to create and publish our first RaCEEs. And you can see in this article, the authors talk about life years and quality adjusted life years. So you got an indication of which outcomes they used. And this is the kind of information you will need to extract following this session after today. So information about the outcomes used in the study. And then just to show you how we summarize this information in our RaCEE, we were basically drafting a sentence around what the authors did and they estimate the incremental cost effectiveness ratio, which involved determining the average cost, life years, and quality adjusted life years. So it was simply a paraphrase of what they did in the methods. Yeah, okay, so this is Misael's slides, and I'll stop sharing mine, but before we move to Misael part, do you have any questions? Okay, over to you, Misael. I think you might be on mute, Misael.
Sorry, apologies. So what is quality of year, quality adjusted life years? The quality adjusted life years is years of life multiplied by quality of life. So it's a weighting combination of the length of life times the health-related quality of life, which is picked by a questionnaire. So as Valerio said, this helps comparability across different diseases and is based on individual preferences. How we construct, and the quality of life goes from 0, death, to 1, perfect health. So if the weighting is 1, so the quality of life will be the number of years additional. And if the quality of life is 50%, then 1 additional year will be valued as a half year. So, and how we construct this quality of life? This is coming from the health states, which comes from a questionnaire, usually attached for a specific study in the randomized controlled trial. So they add to that specific drug, to a specific treatment, they perform this questionnaire. And this is combined with utility scores that is not coming from a specific study, but is coming from the overall population, from the overall system. We combine these two, and combining with survival, we have this quality measure. So how it works? This is the questionnaire, the most used questionnaire. It's called EQFID, and the EQFID has 5 dimensions and 3 or 5 levels. And the dimensions are as follows. First is mobility, self-care, usual activities, pain and discomfort, and anxiety and depression. So it has these 5 dimensions, and in each of them has 3 or 5 levels. In the version of 3 levels, we have no problems, some on moderate problems, and unable or extreme. And in the version of 5 levels, we have no problems, slight problems, moderate problems, and severe, and also unable to walk, unable to do self-care. And from all of this, then we will have this measure of a unique score that I will explain in the following slide. So this is a taste of 1 questions. For example, for the mobility questions, the questionnaire will be under each heading, please tick one box that best describes your health today. And on the EQ5D 3 levels, we will have three options. I have no problems in walking about. I have some problems in walking about, and I am confined to bed. In contrast, in the EQ5D 5 levels, we will have, I have no problems in walking about. I have a slight problems in walking about. I have moderate problems in walking about, severe problems in walking about, and I am unable to walk about. So we have, in one question, we have 3 options, and the other we have 5. So this means that in the EQ5D 3 levels, this questionnaire has 243 health states, which is all the combination of these 5 dimensions by 3 levels. Whereas in the EQ5D 5 levels, this questionnaire will have over 3,000 health states. So now, this will be combined. The questionnaire is applied for each product, to each new drug, new technology. And this will be combined with this table, which comes from the value set for the England population. The source is Devlin. This is a paper published in 2018. They surveyed randomly, representatively, about 1,000 people who live in English. And they perform these questionnaires and done some discrete choice experiments, and they arrived at this table. So I will explain how to read this table. So if you see, we have 5 levels and 5 dimensions. So mobility, self-care, visual activities, pain, discomfort, and anxiety and depression. And in each of them, we have not 5, but 4 levels, slight, moderate, severe, and able in each of them. That is because the baseline, no problems, is subsumed in the constant, so which is a statistical method. But never mind. It's just to say that if I don't have any problems, so I am not penalized. So my health status is not penalized, it's not reducing. And then we have these estimates in this column. So constant 1 means perfect health, okay? So everybody has perfect health, it's constant 1. And then you can put here the number, no problems, 0, 0, 0, 0, 0 in each of them. And then we will subtract. For example, the basic is 1, so that 1 is the maximum value, of course, in this model. And then if I don't have any mobility problems, I will subtract 0. Any problems in self-care, subtract 0, and so on. Which means that if one individual marks the first option for each of them, they will have a perfect health, the value of 1. So with this in mind, we can read the first block of results here, okay? So mobility, for example. If somebody has a slight problem in mobility, here, this parameter, it says 0.058, which means, in practice, 5.8% of reductions in quality of life, okay? So if somebody says, I have moderate problems in mobility, then the reduction in quality of life will be 7%, 7.6 exactly. If someone says severe, 20%. If someone says unable, it will be 27%. 27% in reduction of quality of life. And then we will go to the following, self-care, and do the same. We will subtract. Okay? We can do this math. Okay? What happens if somebody has the worst health state? So is unable to move in mobility, unable to do self-care, unable to do usual activities, and so on, then if we do this, the value will be minus 28.5%, actually negative, which is worse than death. About 5% of all possible health states are negative, which means those health states are considered worse than death. So, which is actually an improvement from the previous model that with equified the 3 levels has over 30% of health states that has negative values. Okay, but this is the idea. And from this table, we can see which one is the health state that reduce most utility. And you can see here in pain and discomfort extreme, this one reduced by 33.5%. If someone has pain and discomfort in an extreme way, so they will reduce their quality of life by 33%. That one alone, even if the others are fine. Okay. So, and this is how this table is read. Remember, this comes from the population. So how the population is valuing each of these states. And the previous, okay, let's just go back. So we have here the health states in the first bit. That health states comes from the intervention, from the drug, from the new technology in the RCT. So each individual in the RCT will have this questionnaire. And then we will map each health states to these utility scores, which is in this table. So let's say that somebody mark this sequence, 2 for the first dimension, 3 for the second dimension, and so on, 5 for the 5 dimensions, which is anxiety and depression. So how we estimate the utility value for this state? Okay, first, in the mobility, they will have slight problems, which is valued at a reduction or a penalization of 5.8% in their quality of life. And then in self-care, they will say they have moderate problems, which is a further 8%. And in the third dimension, they will have slight problems in performing usual activities, a further reduction in 5% in their quality of life. Pain and discomfort, 27%, and anxiety and depressions, 28%, which overall will have a quality of life of 24%, which means each additional year in this health stage will be about a quarter of life in a full quality of life. Okay, so this is how this works, and this is how we compute quality of life per each participant, and then we can add, and then we can compare this with the state without treatment. Okay, this graph is really interesting. So if you see the lower graph, which is below, this curve is without treatment. And the time here is a time that the participant is living. So this is the additional years of life. And the quality of life is from 0 to 1. So it is expected that without treatment, they will live less, and also they will have lower quality of life. So this is and the aim of the treatment. So, and with treatment, they will be extended the life and also the quality of life. So the quality will not be reduced so dramatically. So the difference between these two curves will be the QALYs gained from the treatment. And then from this, we can do the cost effectiveness, because this will be the outcome of this treatment. Okay, questions? And if not, over to you.
Thank you, Misael. Let me share my slides. Okay, I will try to cover the last few slides quickly, and then we can have questions about the QALYs and anything else. Right, I'll talk about the criticism of the QALYs. Now, Misael did a very good explanation how the QALYs work in terms of estimation and calculation. I mentioned before that there are some criticism to the QALYs. First of all, there are some equity concerns that, for example, with the QALYs, when we calculate QALYs, a QALY is a QALY regardless of who gains and who loses it. So if you are a younger person, a QALY will be meaning the same to you as if you were an older person. That could create some equity concern. Of course, if you are in your older or later stages of life, having an additional QALY might mean more than for a younger people. So there might be some discrimination, equity discrimination that we need to consider. At the same time, we talked about the threshold before in the UK is between 20 and 30,000 pounds per additional QALY. That has been that threshold has been lifted to 50,000 pounds at times for end-of-life care drugs. So again, there'll be some benefit from increasing the threshold for older people, which again could create some equity concern and equity discriminations there. Another point that people often pick on QALYs is whether there is, or more on the Q5D, on generic quality of life instrument, is whether they capture all the relevant aspects of an intervention. So all the relevant things we need to consider to measure the effectiveness of intervention. When we apply or when we administer the Q5D, we often don't think about the process of care enough. We also don't think about the different nuances of a specific effect of an intervention. So there are other outcome measures, which, for example, are more disease-specific, which enables us to really capture more about what is relevant for example, cancer patient, diabetic patients, and so on. But when we apply disease-specific outcome measures, then we are not able to measure QALYs, because we are not able to exploit, let's say, a survey of the general population, which gives us utility values for specific health state obtained from a disease-specific outcome measure. So there are ways, though, where we can map the scores from disease-specific outcome measure into UQ5D scores, and then we can calculate QALYs like that. So fortunately, there are ways around that. So by using this alternative approach, we are then able to use disease-specific outcome measure and capture more relevant aspects of an intervention effect. Another strand of research lately has tried to establish if people are capable of being or doing certain things, rather than measuring just their status. So not measuring just what I'm doing or what I am at the moment, if I'm mobile or not, but whether I'm capable of doing something with my particular health state. And you got alternative measures that are out there. For example, the ICE-CAP is one of them, which is based on 5 attributes: stability, attachment, autonomy, achievement, enjoyment. And you can see how they differ from the dimensions used in the Q5D, for example. And these are these are other dimensions which will be relevant for some health or disease areas. Lastly, externalities are really important. They are not often considered when we measure the QALYs using, for example, UKFD. When we talk about externalities, it's mainly effects on other people. So if you think about measuring the effects of an intervention for people with disability, you will have to consider also the effects on people providing care, which are very important, whether that particular intervention will have any benefits or disbenefits to people providing care. And often with just measuring the qualities of patients, we overlook the potential effects on other people. If you want to know more about the QALYs, Luis and I recorded a QALY vlog not so long ago, and you can access this vlog by clicking on the link. And we also share an article about the QALYs, which is just off the press because the QALYs just turned 50. So it's been around for 50 years now, and I will share an article which summarizes all the characteristics and pros and cons of using QALYs. Discounting. So this is the last bit I want to cover today. Discounting is used in economic evaluation because we need to consider that costs and outcomes will not only materialize often just for 1 year, but they will occur in the longer term for in 2, 3, 4, 10 years. So it's important to consider that future costs and outcomes will be discounted, will be valued less. Why is that? There are some empirical evidence that highlights how people in general are impatient. So they want to consume something now rather than waiting for it in the future. They're often, as people, we're often scared about catastrophic events. So we're rather having something now rather than perhaps losing it in the future for any type of a catastrophic event. And again, something that you consume today will give you more benefit now rather than something you consume in the future. So if you have a lot of health gains now, you will be valuing those health gains a lot rather than health gains you will be probably accruing tomorrow or the day after tomorrow. Because tomorrow you will already be in a better health state, basically. There's a nice recommendation which guides us at the discounting approach for economic evaluation. And in particular, we need to apply a 3.5% annual rate for future cost and outcome. You got a formula here. If you got any questions about this formula, I know it's a bit mathematical, so it's probably hard to digest straight away. But if you have any questions after this session, please let us know. All it does, this formula, is just explaining how we need to consider the future cost and effect will be valued less. And here you got a couple examples from papers where people or authors have talked about discounting. For example, in this one, both cost and QALYs were discounted at 3.5% per annum. The second example, instead, you got a short time horizon, so no discounting was applied. So when you got a very short time horizon, you don't need to apply discounting. Right. I'll just talk about the homework, and then we can have any questions after that. Sorry, we are running a bit late today. So the homework is yet again another table. You will have to complete this table on outcome and data and discounting by Monday, the 13th of January. As usual, you can access the table by clicking on session 4 on Teams. You will find a document with your name, and then you will see the table with the type of outcome data we are going to ask you to extract from the paper, some more information and definition about what we would like you to extract. And in the last column, you can just copy and paste the information from the paper. Usually the outcome data and discounting information should be in the method section, but also have a look at the result tables of the paper. That's usually a good indication of what outcomes people have used, like QALYs or something else, for example. So do have a look at the result tables as well. Right, next session is 13th of January. So we got the Christmas break now. And as I say, we're going to stay online for another 5 minutes if you got any questions. I'm going to send you the placeholder for the workshop today or later today or tomorrow. But in the meantime, I just want to thank you for attending today, and thank you for all the interesting questions and points you've been making. And yeah, we will see you again after the Christmas break. I hope you have a nice festive break in the meantime. Thank you very much.